Hi everyone, our subject today is altered mental status in pediatrics. Basics. An alteration in consciousness, awareness of self and environment may range from delirium, which is irritability, confusion, agitation, to coma. Confusion, disoriented with the delayed or impaired thinking or responses but awake. Lethargy, somnolence, mild depressed level of conscious or sleepiness, but the patient remain easily arousable. Obdentation, further depression of conscious level, significant difficulty to arouse. Delirium, a state is often characterized by alternating periods of lucidity and frequently progress to lethargy or coma. Coma, alteration in level of conscious with no purposeful movement or awareness, not arousable. AVPU, alert, responsive to verbal stimuli, responsive to painful stimuli, and unresponsive. This is another way of definition. A child presenting with any alteration in consciousness must be emergently stabilized before a search is started for the cause. The patient should then be evaluated to rule out a potentially life-threatening intracranial process that require urgent treatment. The Glasgow Coma Scale is the most widely used tool for assessing and monitoring changes in mental status. The Glasgow Coma Scale utilizes eye-opening, motor responses, and verbal responses and is more objective means of describing altered level of consciousness when compared with the less specific terms such as stuporous, obtendent, or lethargic. Any focality or asymmetry of the neurological examination should suggest a problem localized to the one cerebral hemisphere. History. The history should include a recent review of system and the history of trauma, medication, and possible toxic ingestion. Certain component of physical examination may suggest an underlying systemic disorder. For example, certain skin finding may suggest a neurocutaneous disorder, Addison disease, anemia, carbon monoxide poisoning, or infectious condition. Needle track marks and sign of trauma should also be noted. Hepatomegaly can suggest hepatic failure, like in Reye syndrome, or heart failure. Fractured extremity raises the possibility of fat embolism. Toxidrome, such as apnea and pinpoint pupil associated with opiate, help identify a possible ingestion. Patient's breathing pattern may aid in the diagnosis of altered mental status. Hyperventilation occurs with the toxic metabolic encephalopathies, increased intracranial pressure, and metabolic acidosis. Hypoventilation occurs with the many drug ingestion. Other breathing patterns like Chinese stroke, apneutistic breathing may indicate specific site of CNS dysfunction. The odor of the breathing may also be helpful. Many disorders and certain ingestion are accompanied by characteristic odor. Serum glucose and urine toxicology screen are recommended as first-line lab evaluation. Subsequent lab work can be obtained based on suspected causes. Tested to be considered are complete blood count, electrolyte, blood urea nitrogen, creatinine, calcium, magnesium, phosphorus, liver function test, and an arterial blood gas analysis. Blood culture, thyroid study, serum ammonia level, and serum osmolality may be helpful. An osmolar gap and an ion gap should be calculated, especially if ingestion is suspected. An ECG may reveal arrhythmia or characteristic of certain toxidrome. How to approach the child with the altered mental status after stabilization. Perform history and physical examination. Determine a Glasgow Coma Scale. Obtain initial lab, including blood glucose and urine toxicology screen. If the patient clinical symptoms, sign of infection, and no suspicion of head trauma, perform lumbar puncture with or without head CT if suspected brain abscess. Differential diagnosis: meningitis, sepsis, brain abscess, encephalitis, acute disseminated encephalomyelitis, ADEM, infectious autoimmune, and other infection. If the sign and symptoms suggest of head trauma or increased intracranial pressure or focal neurological finding, obtain neuroimaging. Differential diagnosis: subdural hemorrhage, intracranial hemorrhage, abusive head trauma, cerebral edema, tumor, arteriovenous malformation, aneurysm, hydrocephalus including VB shunt, malfunction, brain abscess, vascular insult, stroke, embolism, vasculitis. If there is a suspicion of seizure, please see the previous lecture of seizure. Perform EEG with or without anticonvulsant level. This is seizure or post-ictal status. If it is abnormal initial lab or non-focal exam, is there suspected narcotic ingestion? If it is yes, administer intravenous naloxone. This is narcotic ingestion or overdose. If there is no suspicion of narcotic ingestion, differential diagnosis: hypoglycemia, drug, toxin ingestion, dehydration, diabetic ketoacidosis, other metabolic disorder, arrhythmia, migraine with aura, acute confusional, familial hemiplegic, intussusception, carbon monoxide, hypertensive, hypoxic ischemic, and other encephalopathy, Reye syndrome. Top tips. Nearly 10% of patients with migraine may present with the migraine variant, of which 5% develop acute confusional state. Typically, patients present with the agitation, disorientation, speech difficulty, and memory loss. The majority complained of headache prior to the confusion. EEG is diagnostic in non-convulsive status epilepticus, status epilepticus. IV anti-epileptic drug will normalize the EEG and resolve the acute confusional state. The first step in evaluating a child with psychosis is to ask, is the child on any medication? In adolescent, illicit drugs, cocaine, amphetamine, and ecstasy are a common cause. Psychosis has numerous neurological causes, including brain tumor, central nervous system infection, and most important in adolescent, drugs such as amphetamine, cocaine, and ecstasy. Mental psychosis should include symptoms that is delusion, hallucination, paranoid ideation. Haloperidol is often used to treat acute confusional states. The drug can cause unpleasant extrapyramidal side effect. Procyclinidine is effective antidote. Red flag. A confusional state of migraine often lasts several minutes to hours. It may be the first presentation before the onset of typical migraine attack. The diagnosis of first episode of acute confusional migraine is often difficult, particularly if a patient presents with the symptoms such as sudden blindness, numbness, or paresthesia. Be aware that minor trauma can occasionally trigger a major acute confusional state grossly disproportionate to the degree of trauma. Non-convulsive status epilepticus should be considered in all children with the acute confusional state, even if there is no history of epilepsy. Be aware that patients with the systemic lupus erythematosus may present initially with the psychotic manifestation, personality change, depression, and agitation before occurrence of classic feature like malarash and other. A lumbar puncture is contraindicated in children if they have any of the following: cardiorespiratory compromise, focal neurological finding or other suspicion of mass lesion, signs of increased intracranial pressure or other bulging fontanelle, skin or soft tissue infection overlying the site of lumbar puncture, or thrombocytopenia. MRI is helpful in the diagnosis of acute disseminated encephalomyelitis, ADEM, a condition in which symptoms related to the encephalopathy predominate, like confusion, irritability, occasionally coma. MRI typically show white matter lesion. Autoimmune encephalitis is a much more common cause of encephalitis than the previously recognized. Its presentation is variable and can include behavioral changes, seizure, and sleep disturbance. The presence of specific antibody and MRI findings are helpful in the diagnosis. Rare infectious causes of encephalopathy include cat scratch disease, Rocky Mountain spotted fever, Lyme disease, toxic shock syndrome, and measles. A history of head trauma should prompt an evaluation for an intracranial injury. Other worrisome signs and symptoms include a bulging fontanelle, retinal hemorrhage, focal neurological finding, and signs of brain stem dysfunction, abnormal respiratory pattern, and abnormal corneal oculocephalic or oculovestibular reflex. Signs of increased intracranial pressure include a unilateral fixed or dilated pupil, ptosis, cushion triad, hypertension, bradycardia, periodic breathing, or apnea. Cranial nerve palsy, 6 palsy, papilledema, and a history of vomiting, headache, or ataxia. These are signs of increased intracranial pressure in pediatrics. A head CT is a good initial study and is usually readily available. It will reveal hemorrhage, most masses, and hydrocephalus. Subsequent MRI may be needed to identify infratentorial masses, cerebral edema, infarction, or more subtle CNS finding. Abusive head trauma, shaken baby syndrome, usually occur in children younger than 12 months of age. Children often have no external sign of trauma, although retinal hemorrhage and bulging fontanelle may be evident on examination. Neuroimaging reveal subdural hematoma. A complete evaluation for other injury is indicated when abuse is suspected. An intravenous dose of naloxone is recommended to potentially treat this rapidly reversible cause of altered mental status, like in cocaine ingestion. Overdose and poisoning are common in children. A sudden onset of altered mental status, seizure, and vomiting, especially with a preceding period of confusion or delirium, should raise suspicion for a possible ingestion. Toxicology screen may be helpful, although they may be of limited value because they are not standardized. If certain agents are suspected, tests for them should be specifically requested. Immunosuppressed agents, including steroid, may cause altered mental status. Prescription drugs commonly reported in overdose cases are benzodiazepine, salicylate, acetaminophen, barbiturate, and tricyclic antidepressant. Poisons from household product, alcohol, and illegal substance abuse should always be considered. Many toxins cause a characteristic toxidrome of sign and symptom, including ECG abnormality, that may aid in their identification. Level of consciousness, pupillary examination, and vital sign are the most helpful component in identifying toxidrome. An inborn error of metabolism usually occur in the neonate with vomiting, lethargy, or seizure, although partially or incomplete error may not occur until later childhood or adolescence. Initial lab may suggest a metabolic disorder, acidosis, hypoglycemia, but additional evaluation should be performed if clinically suspicious of an inborn error of metabolism. The evaluation for a metabolic disorder should include a blood for complete blood count, electrolyte, pH, glucose, ammonia, lactate, acylcarnitine profile, and amino acid, plus urine for ketone, reducing substance, and organic acids. A patient or family history of a recurrent episode of lethargy, vomiting, personality change, or frequent hospitalization should raise suspicion for metabolic disorder and prompt an appropriate laboratory evaluation. Neurologic and or genetic consultation should be considered for specific recommendation for testing based on clinical suspicion. In older infants and children, altered mental status may be due to electrolyte and other metabolic or endocrine abnormalities like diabetic ketoacidosis, hypernatremia or hyponatremia, hypocalcemia, hypercalcemia, adrenal disorder, thyroid disorder. Symptoms of apathy and lethargy may initially predominate in children with the intussusception before progression to obvious abdominal pain and bloody stool occur. Hypertensive encephalopathy will be suggested by an elevated blood pressure and possibly elevated renal function test and proteinuria. Children with a chronic cardiopulmonary disorder like cystic fibrosis, congenital heart disease, neuromuscular disorder can experience an insidious onset of changes in mental status due to gradually declining arterial oxygen concentrations. Choking, drowning, or suffocation will occur acute anoxic encephalopathy. Other causes to consider are severe anemia, severe methemoglobinemia, carbon monoxide poisoning, and hypothermia or hyperthermia due to extreme environmental conditions. Rarer causes of encephalopathy include Hashimoto's encephalopathy associated with the high level of antithyroid antibody, acute hepatic failure due to drug or viral hepatitis, uremia, acute or chronic due to renal failure, burn encephalopathy, hypomagnesemia, hyperelimination, thiamine deficiency, and rheumatological disease, systemic lupus, erythematosus, Behçet disease. Psychiatric condition rarely cause coma or stupor in children. Adolescent may rarely present with the psychosomatic symptom, feigning unresponsiveness. The incidence of Reye syndrome, a mitochondrial encephalopathy, has significantly declined due to the decreased use of aspirin in children. It is characterized by an acute onset of vomiting, combativeness, and mental status changes ranging from delirium to coma. Hepatic enzyme level and serum ammonia level are elevated. Hypoglycemia, metabolic acidosis, and cerebral edema may occur. The syndrome typically is associated with the preceding viral infection like varicella, influenza B, A. A child with a known seizure disorder, be sure to obtain anticonvulsant level. Peers and pitfall. Avoid use of atropine in rapid sequence induction since atropine causes pupillary dilatation, limiting the ability to assess pupillary reactivity on physical examination. Not recognizing that intracranial injury may occur in association with the other causes of altered level of consciousness. Not suspecting child abuse. Numerous etiology may be secondary. Assuming that a toxicologic ingestion has not occurred, if the tox screen is negative, most ingestion require specific assay for detection. Assuming that toxicology ingestion is etiology for altered level of conscious, if the tox screen is positive. The screen typically is positive for up to a week after ingestion and may be unrelated to acute altered level of conscious. Thank you for your listening.